in chapter 2, you're going to notice right away that there are a lot of vocabulary words. We're not going to talk about those specifically in this lecture, but I would highly recommend that you learn all of those vocabulary words. We're going to start with talking about the difference between acute and chronic inflammation. With acute inflammation, we're going to have a shorter duration, meaning that that inflammatory process has not been going on as long, and tissue can return to its original state, so repair can begin immediately once the causative factors have been removed. A good example of this in dentistry would be gingivitis. Now, we can have chronic gingivitis, but we can also have acute gingivitis that is repetitive. So we see this a lot in our patients where they come in with an acute case of gingivitis and we do a prophylaxis. The gingivitis goes away, tissue returns to its normal state, but because of lack of home care, they return to us a few months later and they have another acute gingivitis process. So that's just kind of a repetitive process that we see in our patients. Now, in chronic inflammation, we're going to see this last much longer, weeks, months, or indefinitely. With chronic inflammation, we're going to start to see some tissue destruction. As those inflammatory factors come into the area, we're going to see some definite destruction of tissue. Healing can take a lot longer, and there may be some lasting effects in various ways, which we'll talk about some of those. An example of this would be periodontitis for us. So we had gingivitis. Gingivitis was not healed, and then eventually we get more and more inflammatory factors and destruction of the tissues begins to take place. At that point, it has become periodontitis, and we have a lasting effect. We're going to talk about the signs, symptoms of inflammation. So first we're going to talk about localized, and then we'll talk about systemic. Now, with localized infection, one of the signs that we'll see first would be erythema. We've already talked about what this means. It's just generally redness. We see this a lot in our patients. So we would have a dilation of the blood vessels, and hang on. I think I can explain this better visually. Let me just give you some music while you fill in your blanks, and then I'll give you a visual demonstration.
So here's the deal. Let me give you a visual. Let's pretend like this is the skin surface and an injury has occurred. Let's assume that you were stabbed with a pencil. Okay, so now we have a localized injury. Now our big red line is going to be a major blood vessel. And then we have our small blood vessels. So the immediate thing that happens is we get a dilation of those small blood vessels surrounding that injury site. Now, because those blood vessels have dilated, the injury site begins to appear more red. So we get an erythema at our injury site. And then what happens is those dilated vessels have an increased permeability. So they're larger now, and so they become a little bit leaky, and they can get more and more leaky. So the fluid that normally would stay within those vessels begins to leak out into the injury site. Your text is going to go into very great detail about what types of fluid are escaping and why, and frankly, you guys don't need to know all of that. What you need to remember is that first we have redness as an increase from those small blood vessels and the dilation, and then because of that dilation, they become more permeable and start to leak fluid. For a variety of reasons, but that's essentially what's happening. Now, as that fluid continues to leak out, then it starts to cause swelling of our injury site. The swelling on that injury site can become so severe that the tissues around it are being compressed, which means that the nerves are being compressed. And then the nerves start to signal to the brain that there's pain in the area, that something is not right. Now, our bodies are pretty dang cool. So sometimes, if there's an opening, the body will try to get rid of that extra exudate in any way that it can. So it begins to find any type of burrow, any type of opening to get out. Because if that exudate is severe enough, the body cannot properly heal. So once it burrows its way to the surface, then you would see a formation of a pustule. And eventually a fistula would open up and some of that pus would begin to drain. And once it begins to drain, then we would feel relief from the pressure that was on that area. So if you guys have ever watched like Pimple Popper MD, don't act like you don't know who that is. She's pretty awesome. And she pretty much does this for a living. So when people have a ton of exudate that is causing problems and not draining on its own, she goes in there and cuts an opening so that the excess exudate can come out. That is very much a simplification of what she does, but essentially that's a lot of what she does on the show.
With systemic inflammation, we are most likely going to see a fever. So pyrogens are the fever-inducing substance that's released from white blood cells or from pathogenic organisms. When they release those pyrogens, that substance signals our hypothalamus to increase our body temperature. But why? Now remember that our bodies are built to fight infection and inflammation. So if there's a foreign substance causing systemic inflammation, such as a bacteria, a virus, a cancer, a fungus, then our temperature will rise in an attempt to kill that organism, because often those organisms cannot survive in a higher temperature environment. And what's the first thing we do when we have a fever? We take Tylenol or ibuprofen to reduce our temperature, which actually counteracts our body's attempt to kill that foreign substance on its own. So if a fever becomes intolerable because it's too high, or you have a headache, or you're just really lethargic, it makes sense to treat the fever. But if the fever is tolerable and not too high, it's actually better to let our body do the work it was designed to do and keep the fever. Systemic inflammation will also often reveal a leukocytosis on lab work. What does that really mean? Well, there's an increase in white blood cells, especially with infection. So if you go to the doctor or the hospital and you say, I think I'm sick, and they take blood work, they're looking to see, is there an infection somewhere in your body? They can tell that by the amount of leukocytes that you have in your blood. We could also have an enlargement of our lymph nodes. So we would have a hyperplasia in the lymph nodes. This is something that you're going to hear a lot in your career in continuing education courses in regards to the C-reactive protein. We know that this is an inflammatory marker that increases during periodontitis as well. So remember that C-reactive protein, because you're probably going to hear it again. Chronic systemic inflammation is linked to a lot of other disease processes like hardening of the arteries and insulin resistance, even Alzheimer's and cancer. So systemic inflammation is a big deal. Having said all of that, you guys need to know the cardinal signs of inflammation. there are 5 cardinal signs of inflammation: redness, heat, swelling, pain, and loss of function. Redness, heat, swelling, pain, and loss of function. Here is our first submission for Lecture 2 credit. What are the 5 cardinal signs of inflammation? Remember I told you earlier, when we have inflammation, systemic inflammation, we will have a leukocytosis. The 2 types of white blood cells involved in inflammation are neutrophils and macrophages. Now this is a board alert. Neutrophils are the first type of white blood cell recruited into an area of injury. Neutrophils are sometimes called polymorphonuclear leukocytes because of their multi-lobed nucleus. To put it very simply, neutrophils like to swallow their target, and then the enzymes inside destroy the substance that they have engulfed. But they die after they eat their target, and when they die, they inadvertently release some of those damaging enzymes. So there are enough dead neutrophils at an injury site, the enzymes can cause further damage to the tissues. So we like our neutrophils because they serve a very good purpose, but if we have too many of them, then they can actually cause some damage to the tissues as they die off. Macrophages have a single round nucleus and a longer life cycle than a neutrophil, but they can also swallow their targets. But the number of macrophages really pales in comparison to the number of neutrophils. Biochemical mediators in inflammation. These are the recruiters during the inflammatory process. They like to seek out and recruit various substances during the inflammatory and reparative process. The kinin system is the system that is active during early inflammation. This is what causes those vessels to dilate and become more permeable. And then we have our clotting mechanism, which is activated from the dilation and permeability of the vessels during the kinin system. And then the complement system refers to a system of proteins that activate other proteins. So some components of the complement system can cause cell death, and others can actually attach to the bacteria and cause the white blood cell to come and engulf it. That process is actually called opsonization. One thing we may see with chronic oral inflammation is the formation of a granuloma. This is actually a picture of a pyogenic granuloma. Now the text is going to tell you that a pyogenic granuloma is seen more often in pregnancy, but every pyogenic granuloma I've seen has been in a non-pregnant patient, and I've seen several in men. But granulomas form as a result of chronic inflammation as those macrophages begin to group together in an attempt to enclose the inflammatory substance since the body has failed to destroy it. These are quite persistent, and once formed, they often have to be surgically excised. We're going to talk more about granulomas in just a little bit. Sometimes we want to block the inflammatory process if it becomes too symptomatic. For instance, if you have an exaggerated response to a bee sting and you break out in hives, well, we want to suppress that histamine response to that toxin and prevent anaphylaxis. In that case, you would take a histamine blocking drug like Benadryl. And here's a fun fact. Benadryl is the brand name of diphenhydramine. So if you need to buy Benadryl, you can buy the same exact drug in the generic form if you just get diphenhydramine. It's a whole lot cheaper. Or perhaps you're having an asthma attack and it's persistent despite the use of an inhaler or a nebulizer, if the inflammatory response persists, it can cause further damage as those neutrophils die. So we need to suppress the immune system with something more potent, like a steroid medication. Prednisone is a steroid anti-inflammatory drug which suppresses the immune system. There are a lot of different types of steroid medications, but prednisone is one of them. The downside to using a potent medication like prednisone for longer than 2 weeks is that the body becomes very susceptible to infection because the immune system has now been severely suppressed. So prednisone and any other steroid immunosuppressant medication become of particular interest to us as hygienists because we don't want to go in there and stir up a lot of bacteria in a patient who is now immunocompromised without knowing if we're going to put them at risk. So if you look in your clinic manual, you're going to see a list of red flag medications in the Common Conditions Guide. If your patient is taking any of those medications, he or she might need a med consult prior to receiving any invasive care. That's something that you're going to want to know before you bring that patient in. Because if you bring a patient in and they're on one of those medications and you didn't catch that prior to them coming in, we're going to ask you, did you ask them about their medications? Did you notice that this medication is on our red flag list? Why didn't you, ask Ms. Norell if a med consult was needed? So it's up to you to start thinking like a provider and being prepared for those appointments.
Here is your second submission question for Lecture 2. On what page in your clinic manual can you find the beginning of the Common Conditions Guide?
Hyperplasia, simply put, refers to an increase in the number of cells. We see hyperplasia in the oral cavity a lot as a result of inflammatory response. Often the hyperplastic tissue will subside if the threat decreases, but sometimes that tissue does become permanent. So one example would be gingival hyperplasia during ortho. Hypertrophy is an increase in the size of a cell. So an example would be cardiac muscle that has increased as a result of chronic high blood pressure. Atrophy, with atrophy we're going to see a wasting away of a cell or a tissue or an organ or the whole body. This happens as a result of disease or hormones or disruption of blood supply. And within the muscles, we see atrophy anytime cells aren't being used, like a person who's on prolonged bed rest. Regeneration and repair. You're going to want to be able to understand the differences between regeneration and repair. During the healing process, our tissues can either completely regenerate or undergo a reparative process. When the tissues regenerate, they're as good as new. All of the disease has been successfully eradicated and there is a return of normal structure and function. So for instance, with acute gingivitis, if there is biofilm reduction and the patient does very good with their home care and prevents that biofilm from building back, then we would see a complete turnaround and normal structure and function would return. However, when our bodies cannot regenerate tissue because there's been too much damage, then our body attempts a final defensive mechanism of repairing the tissue. Now, when the body has to repair tissue, complete healing is not possible. So sometimes those live and functioning cells have to be replaced with non-functioning cells, and that leads to the formation of scar tissue. So if you look on your body, you see somewhere where you have a scar, that means that your body was not able to regenerate that area and it had to undergo a series of repair. What happens during repair? Well, on day 1, we have a clot formation. And then the day after, we start to see inflammation with neutrophils flooding into that area. On day 2, we see fibroblasts beginning to proliferate. You're going to want to remember that fibroblasts are an important part of the healing process. One thing that we used to do routinely with periodontal therapy, scaling and root planing, is we would always irrigate the tissue with chlorhexidine afterwards. We did this for years. And some studies are now suggesting that the use of chlorhexidine inhibits the proliferation of fibroblasts. So we don't have as much healing in those pockets when we flood it with chlorhexidine. And then day 7, we start to see that healing is complete, but it's still vulnerable. At this point, you still may have a lot of redness in the area because the tissue is still very thin. But then after about 2 weeks, we either have complete regeneration or we start to see the formation of scar tissue. Now, there are 3 types of repair that our body can undergo. The first one is primary intention. This one is going to be the best because there's very little granulation and very minimal scarring. So an example would be when you have a surgical incision, the wound is closed together with very clean edges and then a very small clot forms. Another example of healing by primary intention would be like a paper cut. Oh, those things hurt, don't they? But when you get a paper cut, it's a very small, clean cut, and it usually does not leave any scarring. When our body is not able to heal by primary intention, then it heals by secondary intention. And in this case, we would see more clotting. So if you get, anytime you're injured, the larger surface area of clotting that you see, the more likely you are to have secondary intention healing. We do see this a lot in dentistry because with tooth extractions, they almost always heal by secondary intention. And during the extraction process, the tissues are damaged and the edges of injury aren't joined together. So then a large clot forms, which increases the formation of granular tissue and scarring is increased. Sometimes when we have excessive scarring, it can cause a keloid. Now, darker skinned people are much more vulnerable to keloid formations, which is a severe form of scarring. When an injury does not heal properly by second intention, it can lead to healing by tertiary intention. We also see this in the oral cavity, particularly when we have an infection of an extraction site or a dry socket. The amount of inflammation from the injury and infection prolongs that healing process. Sometimes the wound has to be redebrided and left open to allow for proper healing, because closing over an active infection can lead to necrosis. So healing by tertiary intention takes a lot longer. Now we're going to start talking about some of the conditions for this chapter. The first one is attrition, and this first set of conditions you guys should have a lot of familiarity with because they're all things that we have discussed before in oral anatomy, and some of them you've discussed again in some of your other courses. So with attrition, our appearance would be a smooth loss of enamel or dentin or cementum because of excess occlusal wear. This is a wearing away of the tooth structure, usually as a result of bruxism. So we can see hypertrophy of the masticatory muscles, particularly the masseter. And here we see this lady has been clenching and grinding her teeth excessively. So she's had, there's the picture. She's had Botox injected to prevent her from clenching her teeth, which allowed for atrophy of the masseter muscles. Now the text says that the cause of bruxism is unclear, but I'm going to have to disagree with that a little bit. We've come a long way in dentistry in regard to myofascial functioning, and bruxism can be caused by malalignment of teeth or even just a habit formed from stress. So when the teeth are malaligned, it causes us to wear away some areas quicker than others, which exacerbates the malalignment. Let me put it to you this way, a different way of thinking. When you think of your car and how the tires wear, if your car is malaligned, you're going to wear away the tires unevenly. And then that is going to then cause more malalignment, and it's a vicious cycle, and it's very destructive. The teeth are no different. So what do we do for this condition? Well, we can realign the teeth by doing some occlusal adjustment. It's like realigning your car. We can adjust it, and then that would greatly reduce the amount of wear and tear from bruxism, or at least slow it down. And another option would be to fabricate an occlusal splint to wear during times of bruxism, but often our patients are not even aware that they're grinding their teeth. So if they do it at night, then we would make an occlusal splint for them to wear at night. Then we have abrasion. The appearance of abrasion is a smooth loss of enamel, dentin, or cementum. And this is caused from a mechanical habit. It's usually found on the buccal cervical area of the tooth, but it can be found anywhere. This is going to be a wearing away of tooth structure from mechanical means like a toothbrush. If there's recession present, the abrasion is going to be much more pronounced because the cementum and dentin wear away much more easily than enamel. But toothbrushes aren't the only cause of abrasion, by the way. I've had a lot of patients who have had abrasion interproximally because they have a habit of chewing on toothpicks or using toothpicks to get food out from their teeth. It's a very abrasive way of interproximally cleaning those teeth. I've also seen notching of the incisal edges from patients who developed a habit of like holding a sewing needle in their teeth. So the treatment of abrasion would also lie in removing the habit which is causing the abrasion to prevent further damage. And then if damage is severe enough, then we could restore the teeth. But, you know, as you can see, there's such a smoothness to the loss of enamel that it would be difficult to put a good restoration in those areas. Okay, next we have abfraction, and these are wedge-shaped deficits at the cervical third, particularly in the premolar area. The cause of this are microfractures of the tooth structure in areas of stress. To give another perspective to this, imagine a fence. And imagine that fence is held up by fence posts, but there's too much stress on the fence. Maybe as a result of like excessive wind or something. Where will the fence post break? Well, it's going to break at the ground. So an abfraction is similar. If teeth are fence posts and they're undergoing excess force and stress, they're going to begin to break at the ground or at the gingival margin. The treatment for abfraction, if there's enough damage and there's sensitivity, we can put fillings in those abfractions, but the core stressor hasn't been addressed, so you're just going to end up with fillings that won't stay in. So we're really just patching the fence post instead of reinforcing its strength. We can prevent further damage by fabricating an occlusal splint, which properly aligns the teeth and gives reinforcement for the stress being placed. Erosion is the smooth loss of enamel or dentin or cementum on the facial or lingual surfaces caused by chemical action. This does not involve bacteria, so it can be from drug use or GERD, gastroesophageal reflux disease, excessive acidic drinks, or even bulimia. So the next time you do a medical history and you see that the patient has checked yes for GERD or reflux or whatever, or you notice that they're on a reflux medication, you should be on the lookout for lingual erosion in the upper anteriors. When these patients lay down to sleep at night, they get a reflux of acid that shoots up and hits the back of the maxillary anterior teeth, which causes erosion. In that case, I would recommend that you take an intraoral photo of the erosion and educate the patient and discuss what's causing that or what's potentially causing that, and then tell them, hey, next time you're at your doctor, make sure you tell them that when you were at the dentist, they said you had a lot of erosion on your teeth and that there may be some type of reflux issue. Uncontrolled GERD can increase the patient's risk of esophageal cancer. So if you can imagine, if that acid is causing this much damage to the hardest substance in the body, what is it doing to the soft tissues in the throat? Now, as a hygienist, you can't diagnose, but you can show the patient the signs and symptoms of disease and recommend a further evaluation. So that's what we would do in this case. The treatment for erosion would include preventing further damage by eliminating the source of the erosion. Now, with patients who are bulimic, it's much more difficult because the underlying cause is psychological. So the patient's unlikely to admit that they're self-inducing vomiting. It's difficult, though, to distinguish between GERD and bulimia, although we do get a particular appearance of bulimic erosion called perimyellysis, and that is very specific to self-induced vomiting. The pattern of erosion with perimyellysis is going to have an erosion of the lingual maxillary arch, and then it will erode the teeth around their restorations, leaving the restoration intact while the tooth structure around it has eroded away. Hematoma, I'm not going to spend a lot of time on this. It's just a bruise. It's a collection of blood within the tissue. There's no treatment needed. We see this a lot of times with the injection of local anesthesia, but it's self-limiting. Linea Alba, you probably remember this one. It's a white raised line that forms in the buccal mucosa right at the occlusal plane. The cause is frictional keratosis because of excessive clenching. I have a very prominent Linea Alba myself. There's no treatment. However, it should clue us in that maybe there is a parafunctional habit with that patient that might need to be addressed. Nicotine stomatitis is going to appear as erythema in a dot-like pattern on the hard palate, and the cause is inflammation of the minor salivary ducts as a result of excessive heat, usually from smoking a pipe or smoking cigars, but it can occur with cigarettes. The treatment for this would be removal of the irritant. It's very difficult because nicotine is extremely addictive. Then we have melanin hyperpigmentation. But this is really, oh man, I really don't like this picture. Melanosis, we know that darker skinned people will have normal pigmentations, but melanosis is really an excess of melanin pigmentation that is new because of an inflammatory process. So I have a little story about this one. Miss Norrell had a friend that had started getting melanosis spots in her gingiva. They were tiny little melanotic spots in a very unusual pattern. She was Caucasian. She had no history of previous pigmentation. She saw several doctors before finally telling Miss Norrell because it was in the mouth. And with more questioning, we learned that she had recently begun taking a medication around that time, and I can't remember the name of that medication, but I researched that medication and I found in the literature where the melanotic spots were a rare side effect of that medication. So Miss Norrell went back and told her to consult with her doctor, and her doctor switched her to a different medication, and the spots immediately went away. So she had spent a ton of money going to all these doctors, and it was just the medication. So, but treatment would be, well, first, in order to really identify a true melanosis, which is an inflammatory process, we would need a biopsy. But like in the case of Ms. Norrell's friend, we were able to find a therapeutic diagnosis. So I just thought that was pretty cool. We would need to remove whatever the inflammatory agent is and allow the area to fade. Sometimes it will fade. In the case of Ms. Norrell's friend, it went away completely. Then we have gingival hyperplasia. This is going to have an increased size of the gingival margin and attached gingiva, which usually involves the interdental papilla, and it can be localized or generalized. Gingival hyperplasia can happen from chronic inflammation. So we can see gingival hyperplasia in severe and prolonged gingivitis or periodontitis. But it also can happen not as a result of bacteria, but from medications. Anti-seizure medications and calcium channel blockers are notorious for causing gingival hyperplasia. Birth control can cause it. It can have hereditary factors. And then there's one that is not listed in the book that I definitely want to mention to you, and that would be an allergy. So sometimes we see in ortho patients, if they're using nickel titanium and the patient has an allergy to nickel, you'll see a severe gingival hyperplasia that begins almost immediately. The treatment would be a removal of those irritants, and in some cases it just won't go away. That tissue has become so enlarged that it just won't subside, and then we would have to do a gingivoplasty. Periapical abscess is going to be shown on an x-ray, and it will show destruction of bone around the apex as a result of those local inflammatory factors. Remember, it's destructive when that inflammatory process begins. We will see some widening of the PDL at the apex of the tooth. This is caused by injury or infection. The treatment is going to be usually root canal and a crown, but sometimes we actually have to remove the tooth and place an implant or a bridge. So you remember we talked about how the inflammatory factors cause swelling and pressure, and that results in pain. The same process is happening at the apex of the tooth, and that puts tremendous pressure on the nerves which are exiting the tooth in that area. So it's very painful, and that's why patients have such pain with a periapical abscess. Tooth resorption, we have internal resorption here, and it's often difficult to identify a cause for internal resorption, but external resorption is usually from excessive force or pressure or inflammation. The treatment for internal resorption would be that we could do a root canal and remove the inflammatory factors that are inside that pulp. So we have an inflammatory process happening inside the pulp chamber itself, but sometimes we have to extract the tooth. With external resorption, we would want to eliminate the causative factor. Once the damage is done, it's done. So the earlier you can catch that, the better off you are. Next, we're going to talk about burns. With burns, they're all going to be very painful lesions, and they are self-limiting. This first one is an aspirin burn. Now, a lot of people believe that when they have a toothache, they should place an aspirin in the gums because it's close to the tooth that's hurting, that somehow it will provide quicker pain relief. But aspirin is a salicylic acid, and so if you place that on soft tissue, it's going to burn and create a blister, and that's what's happened here. And besides, the pain receptors have to be, you have to reach the brain and block the pain receptors to the brain in order to have pain control. So this is just a false belief, and thankfully we don't see this as much anymore. We used to see it more often. Phenol is used in dentistry sometimes, and it can cause a chemical burn. Another way that we get a chemical burn would be with the use of etchant. So if you guys are using etchant and you get that etchant on the tissue, it can cause a really nasty chemical burn. So you really want to make sure you're isolating well, you're being particular about where you're placing that etchant, and then you're rinsing it very thoroughly when you're doing your sealants. And then we can have an electrical burn. I've never actually seen an electrical burn in the mouth. In this case, this child was chewing on an electrical cord. I mean, it's kind of survival of the fittest, I guess. You're not going to see this very often. And then finally, we have thermal burn. You're going to see this one all the time. Well, think about when you eat a hot piece of pizza and you burn the roof of your mouth. This is what it looks like. So the first thing that I ask a patient when I see marks like this, particularly on the lingual of the hard palate, is if they've recently burned their mouth on something. They'll remember burning their mouth. This type of burn is also going to be painful, but thankfully burns are going to heal very quickly in the oral cavity. The oral cavity heals very quick. Okay, lesions associated with cocaine use. We can see burns from the crack pipe or ulcerations. And then in extreme cases, we might see palatal perforation. Elimination of the cause is the treatment. And with palatal perforation, obviously we would need to refer them to a medical doctor. Traumatic ulcer. So here we have a patient in ortho. If you've ever had ortho, you have experienced a traumatic ulcer. They're very painful. They can last 10 to 14 days. And to treat that, we have to eliminate the cause. So in this case, the braces are the cause. We can't eliminate the braces right now. So what we do is we give patients wax to cover those brackets in an effort to relieve them of their ulcerous pain. Frictional keratosis is exactly what it sounds like. It's an excess of keratin production in an attempt to protect the tissues from a chronic friction. So here we have a very rough restoration, and when that restoration rubs against the tissue there, it's just causing chronic irritation, and so the body is trying to protect that tissue by building keratin. In order to get the frictional keratosis to resolve, we would have to remove the irritant. In this case, the tooth would need to be restored with a different material. Tobacco lesions. So we've talked about tobacco lesions already with leukoplakia and erythroplakia, but in addition to the color descriptors, what is really going on here? So again, the body is trying to protect itself by building extra keratin in that area. So microscopically, we would see epithelial hyperplasia, and that results in a wrinkled appearance of those tissues. So this is a mild case of a tobacco lesion. You're going to see this all the time, and people who use dip tobacco almost always have a tobacco lesion. So removal of that irritant is what we would do to treat these lesions, and as I mentioned before, if you remove the irritant, the body heals very quickly, and you would see a pretty good resolution of that within a very short amount of time. Traumatic neuromas can happen when the sheath that surrounds the nerve gets damaged or disrupted, and then the nerve tissue spills out, kind of like a herniation of the nerve. So that's going to result in a bump, which is very painful. The most common place for a traumatic neuroma is going to be in the area of the mental foramen, and the only treatment for this is to surgically excise it. We've already talked about amalgam tattoos before, but these are going to result in a bluish-gray lesion where the amalgam leaked into that tissue during the placement or removal of a restoration. So think of it sort of like pieces of shrapnel that get caught in the gums. It's not, really like that, but that's the best analogy I can give you. Sometimes we see these on radiographs, and that can help confirm their diagnosis, but you are going to see these a lot in practice, maybe not as much as we used to, because a lot of providers have gotten away from using amalgam, but we do still see it quite a bit. Treatment is generally not indicated unless there are cosmetic concerns. In that case, it would have to be surgically removed, and as you can imagine, that could lead to a lot of scar tissue, so you really have to weigh the pros and cons of whether you want to do anything about that. Solar colitis is something you're also going to see a lot. This is going to be a loss of the vermilion border due to sun exposure. So clinically, we cannot distinguish where the lips begin and where the skin of the face ends. The lips are very dry and cracked. Microscopically, we would see some epithelial dysplasia. There's no treatment needed in this condition, but it is a precursor to squamous cell carcinoma. So we need to advise our patient of what's going on there and ask them to apply chapstick with sunscreen regularly. We want to educate them on what's causing that. We see this in patients who work in the sun frequently. So laborers who work outside, a lot of your elderly patients who have been farmers, they're going to have a solar colitis. I did have a patient one time who came in. He was in his mid-30s, and he presented with a severe solar colitis, but in addition to that, he had a very suspicious lesion. And when I asked him about this lesion, he informed me that his previous dentist just kept telling him to put chapstick on it, but the lesion never went away. I was very concerned, so I went and got the dentist and said, hey, this guy has this lesion on his lower lip and he's got a loss of his vermilion border. Very concerned. In questioning the patient, he worked on telephone poles, so he would climb up these like 100-foot telephone towers and work on them, repair them. So he was up high in the air, closer to the sun on a regular basis. And this gentleman ended up going to the oral surgeon, and in fact he did have a squamous cell carcinoma, and he had undergone 7 reconstructive surgeries the last time I followed him. I don't know whatever happened to him. I know he underwent a lot of treatment for it, and shame on that previous dentist who just kept telling him to put chapstick on it. If you notice something on your patient that doesn't seem right, better safe than sorry. Let's follow up in 2 weeks, and if it's still there, then let's get a referral and have that seen about. A Mucous Seal is a fluid-filled lesion that is caused by drainage from the salivary duct into a damaged area. So when that salivary duct gets damaged, the salivary fluid begins to leak out into the surrounding tissue. So we see this happen most often in the minor salivary ducts of the lip, and you are going to see mucous seals a lot. When that duct is damaged, the saliva will just leak out, and it has like a bluish hue. So if it's close to the surface, it's going to appear blue. It can look like something scary, but that's why it's important to know where the common areas of these lesions are, because if you saw this on the lower lip, you would almost certainly know that this is a mucous seal. These can resolve spontaneously, but sometimes they do have to be surgically removed if they're bothersome. A ranula is a very large mucous seal that occurs in the floor of the mouth. These are associated with the major salivary glands, the sublingual and the submandibular. Ranulas are often caused by blockage of that salivary duct, which cause the saliva to back up. So with a ranula, usually there's some type of salivary stone, and that has to be surgically removed in order to resolve the condition. A sialolith is a salivary stone, and they can occur in the minor or major salivary glands. Sometimes you can see these on a pano, particularly if they occur in the floor of the mouth. And just like a kidney stone, sometimes they can work their way out. You can see in this picture, there's one right there at the opening. We could probably milk it out. However, the larger stones have to be removed surgically. A necrotizing sialometaplasia. Anytime we see the word necrotizing, you want to think tissue death. So necrotizing equals tissue death. Now this one looks pretty scary, and honestly, if I saw this in a patient, I'd probably immediately get the dentist and say, hey, I think this person needs a referral. You're going to see some death of the tissue. So here there's a blockage of the blood supply to the tissue, and it's usually seen at the junction of the hard and soft palate. Now, once they diagnose this, it's pretty self-limiting. So that just means the patient might need some pain control, but with time that condition will eventually heal. But it does usually heal by secondary intention. When the salivary gland itself becomes inflamed, that's called sialadenitis. It's a really hard word to say. If we have a salivary stone that's causing blockage, it can lead to inflammation in the salivary gland itself. It is usually painful because of the amount of pressure from the inflammation and buildup of saliva. So once that obstruction is removed, the inflammation will subside. Sometimes though, if an infection sets up in that gland, we have to provide antibiotics. Okay, we're back to the granuloma now. Pyogenic granuloma. This one you're probably going to see on your national board, so this is another board alert. Pyogenic granulomas are called pregnancy tumors, but like I said before, they can happen in anybody. This one really needs a different name because a pyogenic granuloma doesn't produce any pus, and it's not really a granuloma, but it does contain granular-like tissue. This is an inflammatory lesion that is highly vascular, which means that it appears very red and it bleeds easily. In this lesion, if you were to touch it, it would probably begin to bleed. These can have a sessile or pedunculated base, and they appear to be something scary if you don't know what the cause is. I mean, if I saw this, I'd be very concerned. These are more likely to occur in younger people. Hormones do play a role because hormones can make a person more susceptible to biofilm infection. These occur as a response to injury. They can occur as a response to chronic irritation from like a periodontal infection. These have to be referred to the oral surgeon because they need to excise it, they need to surgically remove it, and they need to do a biopsy to ensure what that lesion is. I had a woman that presented once. She was a new patient on my schedule there for a toothache. And so just, like we've done thousands of times, I asked her how long it had been hurting, and she said 6 months. And I thought, well, what took you so long to come in? And she said, well, I just kept thinking it would go away, and it just kept getting bigger and bigger. So immediately my suspicions were raised because I was like, that doesn't make sense. And I said, oh, okay, well, can you show it to me? And she opened her mouth and leaned her head back, and she had a very large pyogenic granuloma that was covering just about the entire hard palate on the right side and into the soft palate. It had grown so large that it was almost occluding her when she would bite down. She was almost biting on it. And once I saw it, I realized that it was affecting her speech. It looked very scary. It had erythroplakia and leukoplakia, and it was just nasty looking, lobulated and pedunculated. I mean, it just had all the red flags, So I went and I took a pano on her, and nothing really showed up on the pan except that she had perial abscess in the area. And I told the dentist, man, this lady has something really weird. Like, you're not gonna believe it. And he comes in and he's like, oh, I could tell he's trying to remain professional about it. And he's like, okay, well, we need to refer you to the oral surgeon. And he's like, gives me the look, So I go in and I call the oral surgeon's office. I'm like, we need to get this lady in like ASAP. Something's really wrong. And she went, I think later that day or the next day, and it turned out that it was a pyogenic granuloma. And I searched and searched, and I could not find a pyogenic granuloma in any literature that even came close to the size of this one. And I had pictures of it at one time, and I don't have the pictures anymore. So that would be a really, really cool case study, though, to publish. She ended up having the pyogenic granuloma removed. She had to have several teeth in that area removed because the periodontal abscesses were so bad, which had led to the pyogenic granuloma. And then we did SRP on the remaining teeth, and that resolved the issue. A peripheral giant cell granuloma, this is going to look very similar to or just like a pyogenic granuloma, but the cause of these is unknown. So they're also going to be very vascularized, and they're going to occur just in the jaw, where a pyogenic granuloma can actually occur anywhere on the body. They are treated by surgical excision, and they generally don't recur. Irritation fibromas are something you're going to see all the time. These are very dense scar-like lesions, and they are not very vascularized. So they're going to be pale in comparison to the tissue surrounding them. These recur from chronic repetitive trauma. You're going to see these most often on the lip or the buccal mucosa. When the soft tissue is chronically rubbing against a rough tooth surface, a fibroma can begin. And once that fibroma begins, it typically undergoes more trauma, because as we speak and chew, it just irritates it even more. So they don't always require removal, but if it's worrisome or irritating, or it continues to grow in size, then it has to be surgically removed. An epulous fissuratum is a term specifically related to an ill-fitting denture. So because of the chronic irritation, fibrous tissue begins to develop, and if you remove the denture, like in this case, you can see that there's a fold that is present where the flange of that denture met the ridge. Treatment of this requires removal of that lesion and replacement of a better fitting denture. So it's not an easy fix for this one. Chronic hyperplastic pulpitis. You are going to see this, particularly you're going to see it in kiddos when that pulp becomes chronically inflamed. So they've had an inflamed pulp for a long time. It will become hyperplastic and protrude from the pulp chamber. It looks very painful. But the text will say that it's not symptomatic. That's a little bit misleading because a lot of times there's very sharp edges on the remaining tooth, or there's still infection present at the apex. And so if you put pressure on that tooth in any way, it's going to hurt. But it's not actually the hyperplastic lesion that's painful. Treatment involves removal of the tooth. Occasionally, if there's enough tooth structure left, you can actually do a root canal and save the tooth, but usually we're going to just remove this tooth. This one is focal sclerosing osteomyelitis, but it's generally termed condensing osteitis. Most of the time you're going to hear this called condensing osteitis. And that's just a condensing of the bone that happens at the apex when there's been a chronic low-grade infection. And that's just the body's way of overcoming that infection in a different way. So you're going to see this most often on a mandibular first molar, like in this picture here. It's going to be more radiopaque at the apex. It's asymptomatic and there's no treatment required unless there is an active lesion infection noted. Like if you had widening of the PDL at the apex that was still there, still present, then you may have to do a root canal. But in this case, the body has sclerosed that area in order to get rid of that infection. Alveolar osteitis is the technical term for a dry socket. So everyone typically associates this with the removal of wisdom teeth because that's when it most often occurs. But what happens with a dry socket, when that tooth is extracted, a clot is supposed to form. So that granular tissue can begin and the healing process can begin, right? But if the clot is lost too early, usually this happens as a result of smoking. So anytime, if you've had your wisdom teeth removed, they told you afterward, don't use a straw, don't smoke, because that sucking action will dislodge the clot. So if that clot is dislodged too soon, then we have an exposure of that bone, that radicular bone. It's very painful. So if the patient calls the day after an extraction complaining of excess pain, it's really unlikely to be dry socket because it takes a couple of days for that pain from a dry socket to develop. But once it's diagnosed, that socket is going to be packed with medication and pain medicine is given because a dry socket has to heal by tertiary intention. So it takes quite a while for that dry socket to heal. Well, that's it for Chapter 2 lecture, but I did promise you guys an additional bonus opportunity, and the instructions for that bonus opportunity can be found on Canvas. Please make sure you read them promptly, and don't forget to like my video.